Hello, friends. So, I'll be giving an overview on this National Medical Commission guidelines on telemedicine. Actually, it's a telemedicine. Under telemedicine, you can have tele-ICU, OPD service, IPD service, tele-rounds, or whatever one may call. So, these guidelines came formally in 2020, which is enshrined by National Medical Commission. So, this talk I had to give in Chhatrapati Shambaji Nagar on 12th of April 2025. So I'll just take you through what the guidelines say. It's a document, it's a 50-page document, this Tele-ICU bar telemedicine guidelines. So we'll go through what are the key aspects of these guidelines. So as you all know, friends, Tele-ICU is really taking off, and this is a nice cartoon depicting how Tele-ICU works. So this is the hub center where a specialist is navigating a person on site in a spoke center, and these two are connected through a satellite. So this is the nice cartoon which pretty much enshrines the whole concept of tele-ICU, because the on-site person is sort of lost in deep sea and he's being navigated by a specialist in the hub center through the satellite connection. So that is in essence what tele-ICU is. So WHO has put a definition of tele-ICU as where a doctor sort of remotely navigates the people and handholds them into providing sort of a best practice guidelines and care to the patients. And this would help in establishing the diagnosis, treatment, and prevention of the disease. So in TeleSU, that language we use is hub center and the spoke center. So hub center is a specialist who is hand holding the person on site at the spoke center, helping them to treat a patient by helping them or assisting them to in diagnosis, treatment, and even prevention of certain diseases. And tele-ICU services may also extend to conducting research. And most of the literature, if you see, the whole success of tele-ICU is predominantly driven by the online knowledge imparting that happens and the teaching that happens and imparting of best practice guidelines that happens. So that is the key quintessence of the success of tele-ICU, which if you recall, we did very well in COVID across the state. In Karnataka, we had done it. And the whole intent is to enhance the quality of care at the patient level and at the community level. So this is the definition. So basically, a specialist helping another caregiver remote who is present in the remote site in helping to diagnose, treat, and conducting research, and even conduct and imparting knowledge and imparting best practice guidelines to enhance the healthcare at a patient level and community level. So this is the WHO definition. So the background, why tele-ICU sort of a guidelines had to come in National Medical Commission. So there is a backdrop to it. So the quote Winston Churchill once remarked was, "Never let a good crisis go to waste." So there was a crisis, and COVID was a crisis, which led to evolution and systematization of tele-ICU. Until then, see, COVID, it all happened in 2020, and this guideline came in 2020, after which tele-ICU, telemedicine really saw an uptick. So that was the crisis. And there was a premise as to why this guideline had to come. So the premise or the case law that sort of catapulted them to come out with a guideline was this particular case, Dr. Deepa Sanjeev Pavaskar versus State of Maharashtra. So Deepa Sanjeev Pavaskar had done a cesarean section for a lady, and then she was out of station when after 1 week after the cesarean section, patient landed up in had a pain abdomen and some problem. So there was a prescription or a given on the phone by this particular doctor. So that is the sort of a detailing of the case, and the patient died. So the whole contention was that a prescription was given over the phone, and court held her responsible, and this sort of created a pitch for coming out with the guidelines. And as per IPC section 304, Dr. Deepa failed to get anticipatory bail because at that point of time there was no specified guidelines and it was viewed as very detrimental that certain phone prescription was given by a doctor in absence. And that was looked at in a very punitive way by the court of law, and anticipated bail was rejected. And this was later reversed by Supreme Court. So this was the backdrop as to why they had to come out with a guideline so that they provide some sort of a pathway for the doctor community to see to take care of the nuances governing the practice of telemedicine. So that was the backdrop. So the National Medical Council Act in 2019, National Medical Council Act came in 2019, and August 2023 they come out with this NMC code. So, and this NMC code put out the guidelines for the whole Tele-ICU. But later on, this NMC code was put at abeyance, and they said MCI code prevails. So there's a lot of this nomenclature that has evolved, and this has been fluidic over course of time. So they said NMC code, and MCI code, they took it out and they put it as National Medical Commission code. But again, they put this at abeyance, and then they said MCI code prevails. And then this telemedicine practice guidelines was issued under this MCI code. Although we call it as National Medical Commission guidelines, but TPG guidelines, which we presently follow, telemedicine practice guidelines, is issued under the MCI code. And this medical council with Niti Aayog has come out with this telemedicine practice guidelines. And telemedicine practice guidelines is enshrined by the MCI code, and this is under the whole National Medical Commission Act. So that is the sort of a nomenclature that you can keep in mind. And these guidelines are binding for any doctor who practices telemedicine or tele-ICU. So that is something we need to bear in mind. And so when we talk about the telemedicine guidelines, there are other ancillary guidelines that governs the functioning of the telemedicine guidelines. And one of them is Drugs and Cosmetic Acts. So why this is important? Why this is important? Because we prescribe drugs in telemedicine and tele-ICU. So this Drugs and Cosmetic Act regulates the manufacture of the drugs, sales of the drugs, drug distribution and import of the drugs. Why this is important? Because the doctor who is governed by the telemedicine is prescribing drugs. So which means automatically it gets linked to this CDC Act, which is a Drug and Cosmetic Act. Okay, and there should be a license for any drug manufacturer, and they get enshrined under this particular act. And prescription is mandated for any drugs to be given under telemedicine law. So there has to be a formal prescription that needs to happen in even telemedicine. And in prescription, one has to follow different schedules. And in telemedicine, they have categorized the drugs into various categories. I'll show you that. So, and the schedules H, H1, and X is prohibited drugs or schedule X drugs. So these are the categorization of the drugs in the telemedicine. So basically, whatever drugs we prescribe in telemedicine are governed by Drugs and Cosmetic Act of 1940. But in telemedicine, the categorization of the drugs, they have labeled it as O, A, B, and X. So it's a different sort of a nomenclature they have given. Okay. So is that all? So we have now the telemedicine TPG guidelines, telemedicine practice guidelines, which is connected to NMC, which is connected to Drug Act, and it's not even ends there. It is connected to information technology. Why it is connected? Because you are dealing with remote connection. So you see how it is becoming intertwined. It's not only the National Medical Commission which governs, it is the Drug and Cosmetic Act and the Telecommunication Act which governs the telemedicine. So why this is important? Because there's a lot of information that is relayed from one place to another. And all this information, they've categorized it under sensitive personal data information. So because there can be information of the doctors, there are information of the patients, and there are information of other allied specialties, and they have categorized it under sensitive personal data information. And they have created this particular portal called Digital Personal Data Protection. It's called DPDP. So Digital Personal Data Protection. Why these are important is one has to take the patient consent before all these details are stored under these domains of sensitive personal data information, because every patient detail is confidential and it is very sensitive. and they all need to be stored in this digital personal data protection. So one needs to obtain patient consent because you are taking all the data and you are archiving in this particular data bank. So that is why the Information Technology Act becomes very important. And the whole purpose of this act is to safeguard the information that is archived in these sort of portals. So what are the government policies regulating health data? So again, here you will see a lot of different names. First, they introduce something called National Health System, where the health details of all the patients are archived and created as a database. And then they changed to National Health Policy 2017. After that, they changed to Universal Health Care or National Digital Health Ecosystem. So there's a lot of so these names are very fluidic and they've been changing the names. First, they called it National Health System, where all the data will be stored, then National Health Policy, then National Digital Health Ecosystem. When the COVID came, post-COVID, we called it as National Health Digital Mission, National Digital Health Mission in 2020. Because when we were doing tele rounds, we used to call it as National Digital Health Mission in 2020. But now they have again rechristened it into Ayushman Bharat Digital Missions. Now, currently, all the digital sort of a health delivery comes under the umbrella of Ayushman Bharat Digital Mission, ABDM, Ayushman Bharat Digital Mission. And this is rolled out in 6 union territories. And they issue this card, Ayushman Bharat Digital Card. And this card would contain all the details of the patients and all the disease conditions, all the drugs that patient may be taking, all that information that we spoke about is archived in this card. It's like an Aadhaar card where all the health details of the patients are archived in this, and this is rolled out as I'm speaking in 6 union territories. Then there's something called Telecom Commercial Communication Customer Preference Regulations called TCCP regulations. So Ministry of Health and Family Welfare came out with this health data management policy where they have emphasized on data protection and maintaining the privacy of the patient data that has been fed. So if you recall, I told you there is personal digital data protection. Now it's called health data management policy. As a policy, there is an emphasis on protecting the data and maintaining the privacy of the patient details. And the details, not only of the patient, but details of the doctors also is confidential. So which doctor the patient has been seeing, all these are archived in this, and hospital information, because there will be a lot of hospital know-how that will be there in this data. All these are meant to be, confidentiality has to be maintained, privacy has to be maintained. Even the type of drugs that are being prescribed is a very sensitive information. So that data is also managed by this HDM policy, health data management policy. And any healthcare will have insurance tagged onto it. Even all these data are archived, secured, and privacy maintained, because these are all very sensitive information. So details of the patient, details of the doctors, details of the drugs given, details of the institute they work in, and insurance, all these are sensitive, and they are governed by this health data management policy, which comes under Ministry of Health and Family Welfare. And even there is a provision that SMS messages which are sent also have to be protected, because there's a lot of message sharing that happens. So all these are governed by this vertical HDM policy. So after all this sort of evolution, you saw this telemedicine practice guidelines came out. So telemedicine practice guidelines, why these guidelines had to come? To assist RMP, which is registered medical practitioner, for effective and safe medical care. And the safe and effective medical care is meant to be provided by collecting all the information that is and the available resources and the patient needs. So basically, effective care is provided by collecting a lot of information as to the background of the patient and the available resources at the spoke center or on-site center and the patient needs. And telemedicine practice guidelines is only allowed for allopathic doctors. Registered medical practitioner is who's practicing modern medicine, registered under Medical Council of India or NMC, and not by a dentist. And telemedicine practice guidelines cannot be practiced by Ayurvedics, homeopathy, Siddha, Unani, which means in the hospitals now we see physician assistants who are in sort of functioning within the ecosystem of the hospitals. They cannot practice independently, calling themselves as doctors and practicing telemedicine. Right now, the allowance is only for the MBBS doctors in India at this point of time. And the salient features of telemedicine practice guidelines is it is legally enshrined. So it's a legal doctrine. So which means whatever you do is bound by the legal sort of a doctrine. And and telemedicine practice guidelines do not give you any suggestions with the type of software that has to be used, the type of hardware that has to be used. It does not compel you to be specific with regards to data management or interoperability differences between the systems, and it does not allow you to perform surgeries remotely. Why this is important is this does not protect an individual sitting remotely and guiding another person to conduct a surgery. That becomes illegal and that cannot be done. And telemedicine practice guidelines is not sort of covered for any practices that you do outside India and you get entangled in the legal. It does not allow you to. If you are American board, you are governed by American sort of a legal system. If you are offering telemedicine services to Australia, then you are governed by the health systems there, but not by India. So in India, it is confined only to the services you provide within our country. So that is the sort of a norm of telemedicine guidelines. And the type of telemedicine consultation that has been put in practice guidelines is they are categorized into 4 variants: mode of consultation, and the timing of the information, purpose of consultation, and advice to the treatment. So these are the 4 domains of telemedicine consultation. I'll just talk to you details. Mode of consultation is, it could be video, it could be audio, or it could be message. It could be any of these modalities. They come under the ambit of telemedicine guidelines. Timing of information is whether it's real time or asynchronous. So what do you mean by real time? Real time is whatever is happening to the patients and the monitor that is connected to the patient, real time you are seeing it and acting upon the variables. Asynchronous is it is recorded. It is the recorded data you're interpreting and you're acting upon it. And the purpose of consultation can be acute, hyperacute, or chronic. It can be first time consultation, it can be follow-up consultation, or it can be emergency consultation. Advice telemedicine in ICU, you don't give advice directly to the patient, isn't it? So, but a doctor sitting in OPD, he gives advice directly to the patient. So the advice can be to the patient or to the healthcare worker, who can be a nurse, or it can be a physician assistant, or it can be allied health specialist, and most important, it can be to another doctor. So not necessarily it is. See, if you're talking about tele-ICU, it is from doctor to doctor or doctor to healthcare. If we don't give tele-ICU to patient, if it is OPD, it is to the patient. IPD, it could be to the health worker, or it could be to the doctor. So that is the nuance that you have to understand. So these are the types of telemedicine consultations and situations where telemedicine is permitted. So there are situations where telemedicine is unable to establish diagnosis, because there is situation where you may need a lot of other information and you may need clinical examination to establish diagnosis. So if you foresee a situation where you cannot establish diagnosis with the given info, you cannot continue with your telemedicine. Or if only phone call is available or SMS is available, can we make a diagnosis based only on the phone call or SMS? You need more info. If you are needing more info to establish diagnosis, you have to stop and not continue prescribing certain interventions. So that is something that has very clearly elucidated. Because if the patient's situation is very complex like this, the typical ICU patient, we need a lot of information. We need history and we need laboratory data. We need the past records. We need more information. So unless you are sure that all the information provided to you is helping you to make a plan, make a diagnosis, make an intervention, one should abstain from going on prescribing without adequate information, is what has been clearly laid out. And what does emergency mean in tele-ICU? Emergency is where you can provide only first aid, or you can advise on certain life-saving measures, or you can do counseling. At best, you have to do referral. If you cannot do anything and you think it's an emergency, the only advice is refer to a nearest place where appropriate facilities are there to take care of that emergency. So these are very clearly illustrated. What it means is that if you are falling short of information which is helping you to provide a therapeutic solution, one should abstain and do just a referral and stop there, or seek out for more information. So we need more information. The more information you get, the better will be a situation for you where you can create a diagnosis or establish a diagnosis and do appropriate treatment. And MCI code applies to all of this, what you do, which means you have erroneously diagnosed and then say, I didn't have information. I had only this much information, and to the best of the information, I've given you this medicine, and patient dies. You can be held responsible because it was your due diligence to extract all the information which has helped you to make diagnosis. So that is very important. So MCI code applies. If you become erroneous in your establishing of diagnosis and falsifying the treatment interventions, you can be held culpable. So they have created algorithms. So I'll take you through the algorithms because we're talking about guidelines, is not me telling. So there is an algorithm. When the patient comes to you for a first consult, the algorithm says whether you have access to video, whether you have access to audio, or whether you have to access to SMS. So you have to delineate what is your access. And then after that, you have to identify the patient. Once you have identified the patient, the next thing you need to do is get a consent. You have to get consent of the patient. Then once you get the consent of the patient, you need to ascertain whether it's an emergency. That is the first step, to see whether it's an emergency or routine. If it is emergency, then you have to advise first aid and immediate relief measures has to be suggested, and you have to guide referral. This is the pathway for the first consult. If it is not emergency, then they say you have to get detailed clinical sort of a clinical information. You have to get detailed clinical information based on the history, lab data, past records, and any other additional info. You have to get it. If it is not emergency, you have to get past records and then switch the mode of communication, which means you have to obviously get, if you are into SMS or if you're into phone call, you have to get into the video, talk to the doctor and see what the examination findings is, and then communicate accordingly what needs to be done. And at any point of time, a doctor feels that the information is inadequate to make a diagnosis, he can refuse or decline. And same applies to the patient. Patient also can, at any point of time, decline or refuse for continuation of the treatment. And management, so appropriate management, you have to ask yes or no. If there is yes, management is towards health education, counseling, and treatment is list of drugs that are scheduled in O is the first consultation. And if you have a video, sort of a consultation, you can move to the list A drugs. I will talk about what list O drugs. List O drugs are very simple. What is O? Over the counter drugs. So OTC drugs, you can give only on audio or SMS or any of that. If you are convinced that you have a reasonable information, you can give. But you need a video to prescribe list A drugs, which means you have to see the patient. If you have to prescribe list A drugs, okay. And if appropriate management cannot be done, health education, and you have to do a referral. So this is the algorithm they have laid out. If you have to remember, just remember there is some sort of an algorithm that is elucidated in guidelines, and this is to be followed. And what about algorithm for healthcare worker? It is very similar. So either you have to see video, audio, or SMS and identify the patient, consent, see if it's emergency. Emergency means advice first aid, immediate. Same, it's pretty much the same. And here, once you have got appropriate management, if you have got adequate information, you have to see where Tele-ICU management is appropriate. If you are able to plan the management appropriate through Tele-ICU, health education, counseling, and treatment has to be initiated. If you believe at any point of time that appropriate management cannot be given with the given information, you have to refer to a in-person sort of a consultation. So this is the guideline, very similar for first-time consult for a patient or for the healthcare worker. Anonymous consultation cannot be done. This is very important. What it means is there are certain details that you have to capture before you start consultation. So details of the patient has to be there. Details of the doctors also have to be there. So name of the patient, name of the doctors, age of the patients and the sex of the patient, address and email of the patient, phone number of the patient, and registered ID. All these have to be captured before consultation is started. Minor patients cannot be consulted independently. They have to be with an adult to do the consultation. And consent also is very important in telemedicine. If the consultation is initiated by the patient, then the consent is implied. Because if patient is reaching out to you, it is implied that patient has consented. But if a doctor is reaching out to the patients like in Tele-ICU, then a video consent, audio consent, or SMS or email consent has to be obtained. If it is from doctor to the healthcare workers without the patient being involved, then there has to be a patient consent that has to be procured or acquired before you start consultation. So for all Tele-ICU, it means that you have to get a patient consent and before you embark on providing suggestions to the on-site people or the spoke center. And there are certain explanation that needs to happen when you embark on Tele-ICU. You have to explain how it works and you have to explain to the patient. This is for OPD, how to schedule an appointment using the portals. And you have to explain how the data or the confidential information that you have procured, privacy is being maintained. And there has to be troubleshooting if there is technological failure, and there has to be contact info, that all this information needs to be provided for the patient before you embark on telemedicine. This is more for OPD and IPD, not for Tele-ICU. So these things have to be explained. So this is important, folks. Prescribing medicine, telemedicine guidelines divides the drugs into O, which is over the counter, list A, list B, and prohibited drugs. So list O can be done with an audio consult or with an SMS sort of a consult, which are over the counter like paracetamol, cough lozenges, or ORS. List A is where video consultation is needed, where certain topical ointments for skin conditions or eye drops, ear drops, and prescribing oral anti-diabetic drugs or anti-hypertensive drugs. For all this, video consultation is needed. List B is where patient is come for a follow-up and OHS and antihypertensives you are prescribing for the first time. So these come under list B. Even for this, video consultation is needed. Prohibited is all the Schedule X drugs, which is narcotics and other sort of drugs come under prohibited list. So this is the sort of categorization by the guidelines on prescribing medications. So what about misconduct? How do you define misconduct in telemedicine? Misconduct is where the doctor is prescribing treatment without a provisional diagnosis or which I have been reiterating that you need to have made a provisional diagnosis based on the information. If you are unable to make, you cannot provide erroneous treatment. So if treating without established diagnosis can be looked at as a misconduct, or you are leaking the privacy of the patients by sharing certain images, sharing certain sensitive information in different domains. So that is a misconduct. So you cannot share any of the images, any of the lab data of a patient to any other individuals. That can be looked at as a breach of information and breach of privacy. And again, misusing certain patients' data. So patients' pictures or any clinical pictures or clinical examination findings or any lab data, anything you misuse can be looked at as a misconduct. Or anything that you do which goes against the MCI code is conducted as a misconduct. And forcing a patient to do certain things or compelling the patient to do Tele-ICU where otherwise he or she may be willing for an in-person consultation, but forcing them, you please come to telemedicine, you don't need an in-person. So forcing or compelling them is a misconduct. Or providing certain scheduled drugs, like prohibited drugs, become a misconduct. And even advertising oneself on telemedicine services or inducement to garner more patients, which many people are still doing it, is considered a misconduct. So you cannot advertise yourself saying, come to me, I will do telemedicine office services, all that advertisements, which we all know is not acceptable as per the NMC code, but many people do advertise. So this is actually considered as a misconduct. Advertising and trying to solicit their their appointment with a doctor, all these are considered misconduct. Now, what about liability of registered medical practitioner? There are certain duties of the RMPs. So one has to maintain a log or record of all the phone calls or all the telemedicine services, email and SMSs. So one has to maintain a log or record, and one has to maintain the log and record of all the historical archives that the one has done, past records, laboratory data, and imaging. All these records have to be stored, archived, and safeguarded. This is very important. That becomes a liability of RMP. And one has to maintain the log and record of all the prescriptions that gives, become the liability of RMP. And what about the liability of telemedicine platforms? It has to be a registered doctor who can provide care to the patient, which I've already mentioned. It cannot be allopathic, it cannot be dentist, it cannot be other alternative medicine. Name of the doctor has to be registered. Qualification of the doctor has to be registered. MCI number has to be registered before they embark on telemedicine. And non-compliance has to be reported. Non-compliance of the patient to the services also is said to be reported to NMC. And how about artificial intelligence? So artificial intelligence cannot be used to counsel the patients. It has to be in-person sort of a counseling on a telemedicine platform. One cannot use AI programming to counsel the patients. And AI cannot be used as a means to prescribe treatment. It can only be used as an adjunct. It can be only used as a support, assist your decision-making tree or assist in you making certain clinical decisions. But you cannot use AI to directly interpret and give treatment. You cannot use such programming. So these are the liability of telemedicine platforms. And one has to uh, provide adequate info as to who one should be contacting or the addresses to be reached out to for any questions or grievances. So these are all the, so this is in summary, friends, about the whole guidelines that has come. So as you read it, it appears intuitive, but these are all some things which are important to bear in mind and be aware whoever is embarking on doing all this, because you are governed by NMC Act, and any misconduct or legal sort of entanglement you get in, you are governed by NMC Act, and all the rules that apply to a doctor in person, same rules, pretty much same rules apply to the person on Tele-ICU. In fact, it may be more stringent for you because sharing the data, safeguarding the data, and maintaining the privacy becomes utmost. Because when you're working in hospitals, it is hospital's responsibility to safeguard. When you're doing telemedicine, it becomes your responsibility that data is not leaked. So I think that is where the whole challenge is. So thank you, friends. So that's all it is about. So it's a 50-page document. I've tried to simplify as much as possible. So this is something which may be asked in exams. I'm not very sure, but it is good to know anyone who's doing tele. So request you all to submit your valuable work to Journal of Acute Care. So you can visit my website to rehear to this lecture. Thank you. Thank you very much.